about influence of molecular subtypes of breast cancer on outcome. And we as surgeons, when we speak about outcome, it's something to be tangible. Mainly it's the disease-free and overall survival that we always look for. And we are going to go through the past 20 years, what happened due to the molecular subtypes. What makes breast cancer a very peculiar disease that it is a very heterogeneous, that it affects only one anatomic site, yet is phenotypically very variable. Molecular subtypes have been incorporated into the AGCC staging since 2017, and this shows you the importance of the molecular subtypes in predicting the prognosis. We all know the factors that are associated with the aggressive cancer biology and the increased risk for local regional recurrence, and now the biological subtypes play an important role in one of those predictors of local regional recurrence. Why is it important to study the pathology of the local regional recurrence? Because one breast cancer death can be prevented over the next 15 years for every 4 local recurrences avoided. So once we know the reason for the local recurrence, you are preventing more recurrence and you are saving more lives. Since the great work by Peru that was published in Nature in 2000, he studied many genes that were expressed on the breast tumors, and he found out that there are 2 epithelial cell lines of the human mammary gland, mainly the luminal cells and the basal or myoepithelial cells, according to its site on the cells itself. However, he concluded that we are far from having a complete picture of the diversity of breast tumors. We were, however, able to identify 4 groups. And now there are more than 4 groups also. Looking at these 4 groups, we'll find them divided into two parts, the basal and the luminal. Luminal divided into a luminal A, luminal B, and basal type, which are the HER2 positive and the triple negative disease. These are the 4 groups, and if we compare them with the prognosis and survival of breast cancer patients, we find that those groups are much worse than the luminal groups. It's very hard to understand the gene expressing profiling by means of the microarray, but to make things simple, when you have the green composed in one side, this is the good signature. When you have it heterogeneous and the red more on one side, we call this the poor signature, and this is the bad prognostic outcome. These are the 6 commonly used and commercially available tests for the genetic molecular subtyping. All of them are used, but the most common are the MammaPrint, the Oncotype, the XPAM50, and the Endocrine. These are some studies that evaluated the gene expression regarding the prognosis and the incidence of local, regional, and distant metastasis. This was the first study from Amsterdam studying the 17-gene MammaPrint over more than 1,000 patients. They were followed up for more than 10 years, and you can see that regarding the probability of remaining free of metastasis, the good signature at 10 years were much better, with significant difference from those with a poor signature. What is more important is this group, those with lymph node negative patients, although they were the same stage and disease, however, those with good signature and much better outcome compared to those with poor signature. And this shows you the importance of the biological markers, and this obviates the thing of the other aggressive factors like the lymph node status. Then comes the first paper by Peck on the Oncotype DX, where we studied all these genetic factors, and when using the Oncotype, you have a score that predicts the incidence of recurrence and metastasis, and it was divided into 3 groups: the low risk, intermediate risk, and high risk, and you can see the difference, and they were statistically insignificant regarding the outcome of each group of the Oncotype DX. These were 21 genes signature 17 were from the breast tissue tumor itself, and 5 were controlled to study about. And maybe this is the most important study about the biological subtype that was published last year, and we call it the Taylor X, because this predicted for us when we can use the adjuvant chemotherapy in treatment of specific type of patients. So this is the adjuvant chemotherapy guided by a 21 gene expression assay in breast cancer. This was a prospective trial of more than 10,000 patients. Hormone receptors were positive, HER2 was negative, as there no negative breast cancer. Of the 9,719 eligible patients with follow-up information, 69% had a mid-range recurrence score of 11 to 25 and were randomly assigned to receive either chemoendocrine therapy or endocrine therapy alone. The aim or the objective of this study to see if the hormone treatment was inferior to the chemoendocrine therapy. And as we look at this group randomly assigned to have received endocrine therapy versus chemoendocrine, as you can see, over more than 7 years follow-up, there were no significant difference between both arms, and they were all the same, almost the same disease-free survival and freedom from recurrence at the distant site. This is again a very important meta-analysis, a systematic review that looked at the local regional recurrence following breast cancer surgery in the trastuzumab era. This is when we started to use the target therapy for treatment of the HER2 positive patients. It included 7 studies. These are the studies, most of them coming from France, Japan, Turkey, United States, South Korea, and United States. Total of 7 studies of more than 11,000 patients. All received target therapy, the trastuzumab, when indicated. And if we look at this plot comparing the luminal A versus the HER2/neu, there were no significant difference. However, the luminal A had better prognosis. The same applies for the luminal A and triple negative. However, if we look at the luminal B and HER2, it was significantly better outcome in the luminal B. Same when comparing luminal B to the triple negative breast cancer. And both the HER2 and triple negative had the worst outcome compared with the luminal group, which was expected. This same group had done the same systematic review, but 5 years earlier, before the introduction of the trastuzumab treatment. So they compared between both studies, and they found out that a reduction in the local regional recurrence is seen across all subtypes. The overall local recurrence rate decreased from 7.9 to 3.44%, with local regional recurrence rates post-breast conservative surgery reduced from 7 to 2.8%. The reduction across the 2 studies highlights the effect of multiple changes in breast cancer management over the past 2 decades, and hence came the importance of these biological subtypes to really know who would benefit from the adjuvant treatment and to avoid unnecessary treatment for each patient. Because significant variation in local regional recurrence occur across breast cancer subtypes, with lowest rate in luminal cancers and highest rate in triple negative breast cancers. And this gives us an idea about who will benefit from adjuvant treatment, and we have to re-plan our treatment modalities for each subgroup according to its biological behavior. And this highlights the advances in breast cancer management in the contemporary era. So nowadays, these are the expected local regional recurrences comparing each group. So the luminal A, the local recurrence rate within 5 years is around 1.7%. For luminal B, it's 3.3%. For the HER2 positive, 5.7%. And for the triple negative, 7.4%. They have the highest rate of local regional recurrence. And despite that, these 2 groups receive the neoadjuvant chemotherapy and or the target therapy, still they have higher local regional recurrence. However, it's much better than the last 10 years. To conclude my talk, I just want to emphasize that the advantage of the biological subtypes led to the personalized treatment, the precision medicine technique, that not one size fits all. You have to choose the proper treatment for each individual patient. And as I mentioned in my introduction, that we are dealing with a very special disease attacking one anatomical site that has a very heterogeneous various prognosis. From what we just said, it showed the importance of biological staging to determine benefits of adjuvant treatment. Biological staging shouldn't affect at all our surgical decision. And finally, in the era of neoadjuvant systemic treatment, leukoregional recurrence depends not only on the subtypes, but also on factors like imaging, pathology, tumor localization, and surgical outcome. So we have to be very prudent when we are dealing with triple negative and HER2 positive patients receiving neoadjuvant chemotherapy in order to decrease the rate of leukoregional recurrence. Thank you very much.